I got a step page. What do you need?
This is Mr. Molson. He was just brought in by ambulance for severe shortness of breath due to pulmonary congestion. His O2 sats are only 85 on a non-rebreather, and his blood pressure is 200 over 110. This is his wife, Mrs. Molson.
Hi, Mrs. Molson. Mr. Molson, I'm Gina, the respiratory therapist here today. I can see that you're real short of breath, but I want you to try to relax as much as you can while I listen to your chest and get some information so that we can help you, okay? Could you tell me what happened?
Well, he has a heart condition. I was sleeping on the couch. I had my earplugs in, then I couldn't hear anything. And he must have had a really bad night. When I woke up, I knew right away there was something wrong. There he was, laying on the bedroom floor. I called the EMTs, of course. Oh, they came right away. He never listens to anything I say.
Okay, you try to relax. We're going to help him. I hear crackles.
Yes, I did as well in all lung fields. Gina, let me know if there's anything else that you need.
I will. Mrs. Molson, I'm going to step out and get some more supplies. You just try to relax. Everything's going to be fine. I saw a sinus rhythm on the EKG and heard an S3 gallop. He had decreased breath sounds and coarse crackles on inspiration without wheezing. We also drew arterial blood for analysis. His chest film showed pulmonary venous congestion. While going over his initial workup, and despite starting him on diuretics and oxygen via non-rebreather mask, he developed progressively increased dyspnea at rest with oxygenation deteriorating from 85% to 75%. His ABGs also showed ventilatory failure. His physical signs also deteriorated. We considered intubating him, but then decided on the use of non-invasive positive pressure ventilation, using bi-level positive airway pressure. Mr. Molson, this is the mask that's going to help your breathing. It's going to cover your mouth and your nose, but you'll have plenty of air to breathe. Sometimes you feel some pressure with the breathing, but it's normal. It helps open your lungs up, okay? Here we go. Good, good. You're doing just fine. Now you just try to relax and let the machine help you breathe. I'll stay while you get used to it. Okay, sometimes you feel some air pressure going into your stomach. All right, if you start to feel nauseous though or too anxious, then you can take the mask off like this. You just loosen the strap like that, okay? But I want you to try to keep it on as much as you can. Otherwise, we're going to have to go with the breathing tube, okay? All right, would you like your wife to come closer? Okay.
There, that's better, isn't it? Yeah, they're going to make you feel good.
In this case, we decided to place the patient on the Respironics Vision. We used the ST mode, IPAP, or inspiratory pressure, of 12, and EPAP, expiratory pressure, of 6. We set a backup rate of 10 and the FiO2 of 60%. These are fairly typical initial settings, however, adjusted and titrated according to patient condition and response. We also started with a full face mask because that's generally recommended for patients in ventilatory failure. You seem like you're a little more comfortable and relaxed. How's the breathing now?
Whenever he laid down, he used to turn really blue. Oh, he looks much better now.
Mr. Molson, your oxygen saturation is getting better. After the diuretics start to work, we could probably take the mask off.
I hope you're going to start listening to me when I tell you to do something. I don't want to lose you, dear. No.
Once the excess fluid is removed by the diuretics, the patient should do better. The patient was conscious, did not have copious thin watery secretions typical of pulmonary edema, and his airway was patent. Otherwise, intubation would have been indicated. Some people can't tolerate the mask and the non-invasive ventilation. Initially, it can be uncomfortable exhaling against the positive pressure, but once the airways start opening, the patient may start to feel some relief. The patient will need a good fitting mask and a lot of reassurance from the RT.
If tolerated, bi-level positive airway pressure can provide effective reduction of PCO2 improved PO2, pH, and respiratory rate, as well as make the patient more comfortable. For those patients who present to the emergency department with acute ventilatory failure, but with normal levels of consciousness, no major secretion problems, and who are hemodynamically stable, a trial of bilevel or CPAP should be attempted prior to considering intubation and a mechanical ventilation.